So the first patient is a 68-year-old male. This is his urine specimen. So he has past history of high-grade urothelial carcinoma under treatment. So in this voided urine specimen, we see the cellularity is not very high. However, they do have some significantly typical urothelial cells. So here we can appreciate hyperchromasia, coarse chromatin, and increased NC ratio. So it is positive for high-grade urothelial carcinoma, so the patients may still have persistent disease. Usually these kind of patient will under lifelong follow-up because it is very common that the disease will recur. And urine cytology is often one of the very first modality to identify the recurrence. So this is positive for high-grade urothelial carcinoma. In the voidy urine specimen, sometimes the cellularity is low. This is another specimen. This is an instrumented washing urine specimen. So on low part, you can appreciate that we do have hypercellularity and a lot of cell were in fragments. So this is compatible with instrumented urine. So in the background, we can see similar cells with increased nuclear size, high NC ratio, hyperchromasia, coarse chromatin, and irregular nuclear membrane. So this type of individual cell is easier to interpret comparing to the larger fragment. Sometimes the fragment was very difficult to see through. So we were paying attention to these smaller like individual cells in the background. So in this specimen, it is positive for high-grade urothelial carcinoma. That you can easily find some typical high-grade urothelial carcinoma cells. So the patient already had a history of right ureter high-grade urothelial carcinoma, but apparently the patient were very hesitant to receive a curative like a surgery because the curative surgery usually involve like remove of the entire one side of the kidney along with the ureter. So sometimes the patient will ask for more not palliative but more conservative type of treatment. So sometimes the clinician would only do the lesser ablation, but usually it is not very effective. So the patient still have persistent disease. So the next specimen is a new patient. It is also instrumented urine specimen. And for this specimen, it is much easier to diagnose because almost every cell looks like malignant. So here, under a good fixations, sometimes we will have more apparent hyperchromasia, but in this specimen, you can appreciate the chromatin pattern is more hypochromasia with a very ground glass type of pattern. It is not uncommon that you see these features in the under fixation specimen or in the specimen with prominent degeneration. However, you can still appreciate that the other feature include increased size of the nucleus, high NC ratio, irregular nuclear shape, and so this is consistent with high-grade urothelial carcinoma. So the next specimen is coming from a new patient. is a pleura effusion specimen, 68-year-old male. So clinically, he has a large intrathoracic mass with invasion of mediastinum, so consistent with advanced stage lung cancer. So this specimen is kind of difficult to screen because the lesional cell is very, very scant. However, our screeners are still doing a good job by identifying the lesional cells. So here you do see a cluster of cells, apparently with more hyperchromatic chromatin pattern comparing with the adjacent mesothelial cells. The cell shows really high NC ratio and with a three-dimensional and sort of like molding pattern. The chromatin pattern is very like a delicate, and you do not see an like a apparent granularity in the nucleus. So this is likely a salt and paper type of chromatin pattern. So overall, this looks like a small cell carcinoma. So small cell carcinoma, we've seen like 4 or 5 cases just in this week. So sometimes it's like you will see 1 or 2 every 1 month, but just the past week we see 5 cases. And so for the small cell carcinoma, usually in the pleura effusion, the cellularity is not very high. So that's why the screening will be a little bit difficult, because it is not strike you as a typical two cell population, like a very three-dimensional cluster, and it's kind of easy to miss, as you might interpret these as inflammatory cells or something else. But just under low power, these aggregates of hyperchromatic cluster you should pay attention to and go to the high power to see if it is lesion malignant cells. In the cell block preparation, however, the screener do not identify the correct lesion. So we have one dot over here. So these are mesothelial cells. So these are aggregates of rheatic mesothelial cells. So it does not have the small cell morphology at all. So where are the small cell carcinoma? It is over here. So again, you have these very similar appearance. On low power, you see just like a dark, like a cluster without a lot of cytoplasm. On high power, you can appreciate these molding type of pattern. The chromatin pattern again is very delicate. So these are small cells. Here again, these are small cell. So basically, small cell is a morphologic diagnosis. If you have the right morphology and a right clinical scenario, long-term smoker, you don't really need to do any scan to confirm. But we do, the Sanya doctor do order the stent. So this is synaptophysin. So under reconstruction, we only have one cluster of small cell in this cell block preparation, but this is diffusely positive for synaptophysin, as well as TTF1. The TTF1 is not very strong and diffuse, but it is still positive, and you can appreciate with these molding type of pattern, cell in cell pattern. So this is positive for small cell carcinoma, and this is his very first specimen in our department. So the next specimen is relatively unusual. So this is a 67-year-old female with intracranial tumor. So it is a suprasellar cystic tumor. So clinically, they already suspect that this is a craniopharyngioma. And neurosurgeon nowadays, there are a type of surgeon who do not like to do surgery, possibly because they are not very good at that. So they do the transcranial, possibly through the nasal cavity, to do the aspiration, to aspirate the cystic component, and then they do the gamma knife surgery. Use very high like intensity radiation to try to eliminate the cells here, which is I personally do not recommend it, because as you can imagine, craniopharyngioma is not a very proliferative tumor, because the tumor components are mostly mature epithelial cells. So the response for that high intensity radiation might not be very good. Plus, the radiation is also a carcinogen, and then it might induce some other type of malignancy in the future. So, but anyway, here we do see very similar, like a granular type of cyst content, like what we see in Warfarin tumor. Additionally, we do see some epithelial cells, and some of them show the squamous feature. So the clinician also ordered a cell block preparation. So in the cell block, we have very good visualization of these, what we say, ghost-like squamous epithelium. So there were two different types of craniopharyngioma. So if you see these ghost cells, this is consistent with the wet keratin that you will see in the adamantinomatous craniopharyngioma, which is a totally different tumor comparing to the papillary craniopharyngioma. Those two has very different histology as well as molecular signature. So we should just call these as adamantinomatous craniopharyngioma due to the presence of these ghost cell and wet keratin. Plus, the clinician didn't have any surgical specimen for us because he already received the gamma knife surgery. They say surgery, actually it's just a radiation treatment, which I'm not a very big fan of. So we should give the specific pathologic diagnosis, which is adamantinomatous craniopharyngioma. The next specimen is ascites specimen. And this is a patient with a history of pancreatic adenocarcinoma. So apparently, this cancer is very high grade. So difficult to tell where is it come from, but due to the history, this is compatible with metastasis of the patient's pancreatic cancer. So the next specimen is also coming from a new patient. He is a 100-year-old male. So our hospital, our patient population were typically older male, which is not uncommon. You can see some 100-year-old patient. So this is his first pleural effusion specimen in our hospital. So it looks like positive and with a high-grade adenocarcinoma, and it's highly likely to be lung primary. So we would do a TTF1 to confirm the lung origin of this case. So the next specimen is coming from a patient with a past history of ampulla vata adenocarcinoma, and we've seen specimen from these patients before with ascites and with so this is a pleural effusion specimen. So in the prior specimen, we already signed out that positive for adenocarcinoma with focal signaling cell feature. So this is consistent with what we see before in the ascites. So mostly individual cells with very high-grade nucleus, and you can see like eccentric sort of like signaling cell pattern. They were other focus of more cohesive tight cluster. So this is consistent with adenocarcinoma, and the morphology is also consistent with the patient's prior specimen. So let's move to some fine needle aspiration. This is thyroid aspiration. So on low power, we see hypercellularity and scant colloid. Additionally, we already see some multinucleated giant cells here and there. So these looks very much like a papillary thyroid carcinoma just under low power. Here we also see typical papillary fragments with fibrovascular cores. So we only need to go to high power to see the nuclear feature if this is consistent with PTC. So here we see pseudo inclusion, nice coffee bean grooving over here and there. So this is a PTC. So we signing out as TBS category 6 at PTC. So the next specimen is a breast aspiration. On low power, it looks very much similar to what we just see in the thyroid aspiration. So you see larger fragments with some papillary-like branching. So it has a very similar architecture pattern as we can see in the papillary thyroid carcinoma. So in the breast, it is likely a papillary lesion. So when you go to the fragment of the cells, it also does show some nuclear features similar to the papillary thyroid carcinoma. The nucleus is mostly oval shaped. Sometimes you can see grooves. Something uncommon is that you do see very small but distinct nucleolus. That is usually not that you will not see in the papillary thyroid carcinoma. However, additionally, in this fragment, you can appreciate with some smaller, darker bipolar cells mixed with these epithelial fragment. So these cells are myoepithelial cell, which you won't see in the thyroid aspiration. So you see a papillary lesion with very good cohesion and with myoepithelial cells, and even some in the background as a single naked cells. So this is benign. So this is a benign papilloma in the breast. So the location of this lesion, the clinician labeled as just right beneath the nipple, which is also one of the most common place that you will see a sizable like benign papilloma in a larger lactating duct. So this is consistent with a benign papilloma because we do not see any atypical cell with discohesion like arrangement. So we have a lot of PTC today. These specimen from thyroid with slightly less cellularity, but again in the background you only see very scant thick colloid. You do not see any thin colloid. On high power, the cell shows typical architecture and the cytologic pattern of PTC. So this is also positive for PTC. another PTC. Again, on low power, high cellularity, scan colloid, and you already see some giant cells here and there. And then you go to high power. The nuclear feature is very good for PTC with oval shape, like a coffee bean, like a morphology, grooves, disorganization of the arrangement. So this is again PTC. Finally, we have a lung aspiration. So in this aspiration, we do see nice, uniform, monotonous cluster of epithelial cells with very similar morphology to what we just see, which is with oval shape grooving. So the patient actually has a history of papillary thyroid carcinoma. And this is the morphology is compatible with metastasis of PTC in the lung. Usually for the primary lung adenocarcinoma, it can show some similar cytological feature with PTC, such as like a nuclear groove and even pseudo inclusion. However, usually in the lung, the adenocarcinoma, you will see more apparent nucleolus. So this one doesn't show nucleolus at all. Additionally, she already had a biopsy stain, which is positive for POX-A. So this is consistent with metastatic PTC in the lung. So the last specimen is a pap smear. The patient indeed had a past history. So she has been diagnosed with high-grade adenocarcinoma. It is uncertain if it is HPV-independent cervical adenocarcinoma or it is a high-grade endometrial carcinoma. So in this specimen, we can appreciate atrophy type of pattern. The screener do have some dots. So it highlights some cluster of vacuolated cells, some with like a striking nuclear atypia. So this is consistent with adenocarcinoma, and you also see a karyoresis over here. However, I think this is not very clear. There are some other clear foci which is over here. So here you see a large fragments of highly atypical cell, three-dimensional with polymorphism, striking polymorphism. So this is much smaller. This is a much bigger cell. You see mitosis over here. You see abrupt like a mucin secretion. So this is a viable adenocarcinoma fragment. Looks like direct sampling. The other looks like degenerative, like a falling down, and you got it from the debris. And then here we start to see this is chorioresis, right? So this is tumor diastasis. So along this, again, necrosis, tumor diastasis. So these are degeneration. So similar to what we just see, like the screener highlighted. And then go through with the smearing direction again. This is degenerative, but as you can see, very big cells, typical nucleus, and mitosis. So this is also adeno. So this is degenerative. And again, here is more viable. So this is adenocarcinoma. So it is compatible with the patient's past history. However, in the pathological report, they used the term carcinoma instead of adenocarcinoma, so we send this out as carcinoma. Just don't want to confuse with the clinician. But in the pathology report, under the report, it does mention that adenocarcinoma. So we do have the morphology of adenocarcinoma here and there. So this is consistent with the recurrence or persistence of the disease. Okay, that's for all the case today. So I have meeting in the noon and